My friends, so continue with our good time and our good day as we are having here. I hope you guys so far enjoyed the content and the themes that we are discussing in this good day. And we're going to finalize it with Dr. Schwartz. So Alan is a pioneer on the field of neurostimulation in obstructive sleep apnea. He is the one that started this whole thing in the 90s. And besides that, he's just a brilliant guy. So I'm looking forward to hear what else, Alan. And please, come here, please.
Thanks loads. So I guess you're hearing me. Yeah, I don't need that.
I think
I'm wired.
You're wired. That's awesome.
Yeah, terrific. Well, this has been really exciting, and thank you so much, really. Robson Stanley, I can't pronounce the R the Brazilian way, you know.
Exactly.
Hobson?
Impressive.
Yeah, a little bit guttural. All right. Thank you so much for having me, and really great to be with you. This is really, I'm speechless. I really am. The creativity that has gone into this program has been absolutely phenomenal. I think it's emblematic of a couple things. Number one is the creativity that's sort of, nascent here early on at Stanford, perhaps echoed by the memories of Dr. Good, who I did not know, but was obviously a man of many talents, crossed disciplines very, very readily. And I think that's one of the things that really we all share together is that sleep medicine is a highly, highly interdisciplinary field. And so the more we figure out how to talk to each other and speak each other's language, I think the better off everyone will be, most importantly our patients. Well, okay, so my background a little bit. I came through actually as a pulmonary physician, got hooked in the mid-1980s in the early days of CPAP at Johns Hopkins and learned a little bit about breathing physiology and just continued to trot out some basic concepts in breathing physiology along the way. I had a resident many years ago, and his name was Mike. Mike had the misfortune of having me in the ICU as a resident. And before we would go out on ICU rounds, I would go ahead and give a 15 or 20 minute chalkboard talk. Just basic things like how do we breathe, what's a spirogram, what determines our oxygen saturation, et cetera, et cetera. And we went through the whole month, and Mike heard 20 or 30 talks. And Mike had, unfortunately, the misfortune of actually having to come back several years later as a pulmonary fellow. And we matched up together on the same ICU rotation. Halfway through the month, Mike turned to me after one of these chalkboard talks, and he said, "I swear to God, Alan," he called me by my first name. He said, "I swear to God, Alan," he said, "if my memory serves me correctly, you are giving the exact same talks that you gave several years ago when I was a resident." Looked at him sort of cross-eyed, took him by the scruff of his white coat and said, "Mike, I also swear to God that breathing has not changed in all that time." And really, we've heard about a lot of elegant technologies, but the one thing that really the common denominator as we think about treating obstructive sleep apnea is that breathing is breathing. Ventilation, if you restore ventilation, you prevent upper airway collapse and ventilation is restored, the chances are you'll get better outcomes. No, I can't prove it, and I can't prove all of the whys and wherefores, but there's a long distance between, say, the physiognomy that you see in Vincent van Gogh's face, the anatomy, and ultimately the clinical consequences that are alluded to in the last colloquium. The fact that the guy really went a little bit off the rocker. But there's a lot of steps in between that connect that facial anatomy with functional outcomes that can be measured literally every breath. And if you can treat a breath, you might be able to break an apnea, and then beyond that, you might actually be able to treat a night and treat a patient night after night for a lifetime. And then we can talk about cardiovascular, metabolic, oncologic, and what have you. Ultimately, the clinical sequelae that really make a difference for patients and for all the stakeholders in this field. Well, enough said by way of introduction. I'm going to try to make the technology work. By way of disclosure, a bunch of different things. I was at Hopkins for about 30 years, retired from Hopkins about 3 years ago, and joined really what I'm hearing, a lot of different activities, some of which are NIH sponsored in the realm of breathing physiology related to neurostimulation, and others really trying to translate some of these basic contexts, these basic concepts that my resident and fellow Mike and I were talking about years ago, trying to connect that to the patients that we tend to see in the sleep lab. All right, sleep apnea. I probably don't need to go into too much of an introduction here, but, oops, sorry. So most of you know that apneas are really characterized, obstructive apneas are characterized by recurrent periods of airway obstruction during sleep. You have apneas, hypopneas, RERAs, a spectrum of upper airway obstruction during sleep. The acute physiologic consequences are things that we debate about measuring. These are the things that the wearables and the nearables, Mike, thank you, a new term for me. The nearables are able to sort of measure on the fly. This is really, these are just part of a spectrum of upper airway obstruction, which becomes really critical as we think about which therapies to deploy for which patients. We really want to talk about how bad is the underlying sort of pathogenic defect, and that is really the severity of obstruction during sleep. Yes, you do get oxyhemoglobin desaturations, you get arousals, you get sleep disruption, you get morning fatigue, headache, daytime hypersomnolence, and all of the downstream events. Sure whether this is, oh, there we go, okay. And most of you know, and we've spoken about in the first colloquium today with Robson and Mike, we spoke really about the health consequences and societal burden. First, mortality. This is the graph that is always presented from the Sleep Heart Health Study. And it really shows that as a function of sleep apnea severity, there's increased mortality over the observation period of about 10 years. But what is seldom cited is that this is the graph for the men. The women do not show nearly this pronounced a dose-response relationship. And so right off the bat, we need to think about really segmenting our patient population. It's not that women do not suffer, but they may suffer in a very different way. But it's not only the mortality, but it's the morbidity and the consequences there. Abundant studies, largely in the realm of epidemiology, but also in the realm of physiology, that really point out the links between sleep apnea, obstructive sleep apnea in particular, and neurocognitive, metabolic, cardiovascular, even oncologic outcomes. On top of that, though, as we think on a population basis about the burden and the cost of disease, we really think about the economic consequences. And we spoke earlier today about who are the stakeholders here in addition to the patient. But it is the workplace activities and the loss of productivity, the motor vehicle accidents, the loss of life and limb, and a variety of other sorts of psychosocial issues that need to be sort of considered as part of the whole panoply of things that we're treating. Each patient a little bit different, one from the other. Well, when we think about obstructive sleep apnea, we think, well, how do we connect obstructive sleep apnea with all of these remote outcomes over a period of time? We know that obstructive sleep apnea is a really complex disorder. Some of us in the room have really characterized the endotypes. I'm thinking about Eric, who gave one of these talks a couple of years ago, who really think about different mechanisms that conspire to create the patterns that we see on a sleep study, namely the density of these recurrent events, the propensity of an individual to arouse, the hyperventilatory response that ends the first apnea but sets up the next apnea. As someone breathes too much and blows down their CO2, the upper airway muscles, maybe also the respiratory pump muscles, quiet down as the CO2 declines. That sets up the conditions for the next obstruction or central apnea. And so when we think about the characteristics of the apnea, many of you as orthodontists, dental people, or sleep surgeons are really primarily focusing on the upper airway. The process that starts here with the occlusion. I'm not sure whether this works. Yeah, maybe, yeah. Starts here with airway occlusion, but everything else, or airway obstruction, everything else that occurs downstream inside the obstructive episode is really a function of a variety of other physiologic patient traits or characteristics, namely the rate of desaturation, the propensity to arouse. At the arousal, the airway reopens, but the gush, the inrush of air, determines really to what extent ventilation is restored or overshoots. And it's that overshoot that I mentioned that really sets up the conditions for the next apnea. But your focus is primarily, based on your field of discipline, your focus is primarily directed toward really identifying and understanding what's going on here. And in that regard, I confess that I'm rather simple. I'm simplistic. I'm just a breathing doc. I don't know all about the anatomy and the structures that you all think about as a sort of day-to-day language and that guides your clinical impressions. Oh, got it. Okay. And so the field sort of opened up dramatically with the advent of CPAP in the early 1980s. And for at least 10 to 15 years, CPAP was the panacea for anything. Anything that snored and stopped breathing, CPAP was it. And we asked our patients, just as you do in the clinic, we ask our patients, do you snore anymore? Do you use your CPAP? And all of them swore by the machine. Compliance was nearly 100%. No one had any problems with CPAP whatsoever. And that persisted, that situation persisted until the mid-1990s. CPAP actually, we started to monitor people's usage patterns with CPAP, and we realized, oh, lo and behold, we went into a study in the mid-1990s on CPAP usage, objective monitoring of CPAP usage. The a priori hypothesis was that people would use it for either plus or minus, either greater than or less than 6 hours a night. And we would bucket the patients into roughly two equal categories, those who used it for over and those who used it for under 6 hours a night. Well, when the data started streaming in, and this really relates to, all of the data streaming in, from every other device and sensor that we have around and on the body, the data started streaming in, we realized we couldn't possibly cut the patient population into two roughly equal parts based on a 6-hour threshold. Nor could we cut the patient population based on a nightly use of CPAP. And it was really for convenience purposes that the definition of compliance was defined as, Cleet, what's the definition? Absolutely. And Medicare and every other payer has adopted that standard. But that was really just a fiction of the fact that we couldn't make any meaningful comparisons by cutting the patient population at a higher level of CPAP adherence. Well, these guys showed up on a flight to Florida. They were snowbirds one winter. One of them was my patient. And it turns out, and it's a common scene now, you can see anytime you're going through TSA lines that someone or another is going to be trundling their CPAP device. You refer to it, Mike. But they all strapped up, probably blew a fuse. I don't know exactly what happened. But this was really the situation that we really believed that in about 1990 that everyone really used CPAP. That was the end of the story. And it made me as a respiratory physician, probably you all as sleep surgeons at that time, somewhat numb to thinking really about the mechanics of the upper airway and how we're going to relieve the obstruction for those who can't use it. Because everyone professed just like this, that CPAP was a godsend. And indeed, for many, many patients, it was. It was so much of a godsend that if I could figure out how to advance the slides, it really reminded me of this Far Side comic. Because Doreen, who is a veterinary student, reads the textbook of equine medicine. And for every diagnosis, whether it be broken limbs or hoof disease, swollen belly, just simply ornery, we heard about that, mood and psychological changes. For every one of those diagnoses in the equine world, the diagnosis, the treatment was the same. Just shoot the animal. And this was really the state of the art as we knew it until we began to sort of look in detail with objective monitoring. So what I'd like to focus on today is what do you do? And how do we connect the dots between you all and your world, which really deals primarily from the anatomic framework and the breathing situation, namely ventilation and upper airway obstruction. And so what I'd like to do is I'd like to sort of just hammer out a couple of basic principles. How do we model the obstruction? For some of you, this is old territory. But we'll talk briefly about what is a measure, quantitative measure of the airway collapsibility, and we've got two measures that we're promulgating. And then we'll use these measures to really look at the acute effects of neurostimulation techniques, one of which, hypoglossal neurostimulation, has been in existence for quite a while. FDA approved in 2014, so it's part of our therapeutic armamentarium. But another really is in the development phase. And so we'll really sort of turn the clocks back to the 1990s when we first began our studies on hypoglossal stimulation and just really play it again, Sam. Replay the same tape and trot out the same concepts as we examine the potential for another neural target that may be effective in treating sleep apnea. And I say maybe because we're looking at acute physiologic surrogates. We'll wrap things up at that point. Again, this is your view of the airway. It's really highly anatomically based. My view has nothing to do with anatomy. Something's collapsing in the back of the throat. John Remmer showed it in a classic landmark paper in 1978. He demonstrated that the obstruction was in the throat and that was really key to the pathogenesis of the disorder. And there are somewhat more rigid segments that are upstream and downstream of the segment, to that collapsible segment. Upstream might be considered the nose from the CPAP point of view. We're applying a positive pressure, and airflow only knows where a pressure gradient tells it to go. So if you apply a positive pressure to the nose, airflow will stream into the airway, into the lungs. And the only back pressure, the only thing that's going to impede the flow, is really going to be how collapsible the segment is and how severe the blockage is in the throat. And that blockage is really governed by, if you will, the way we originally sort of thought about this is it's governed really by a surrounding tissue pressure. And so if you've got a Penrose drain of a throat, but the Penrose drain is mounted in a box and you just increase the pressure around the drain, you'll collapse the Penrose drain and ultimately obstruct flow completely. And that happens any time the pressure in the box, the surrounding tissue pressure, gets higher than the pressure that you're applying at the nose. And so let's take a look at that. The first concept that we had to refute, we're sort of taking a dance through sort of recent history here. We had to refute the notion that you could actually suck the airway closed just by breathing in deeper. And so you're not sucking your airway closed, so the story went, primarily because you're just sitting there and it's not taking you too much effort to generate enough airflow into your lungs. But if only I could really connect your trachea to a Hoover vacuum cleaner, and apply minus 100 or minus 1,000 in pressure, I should be able to suck your airway closed. So the first thing we sort of stumbled on when we thought about the mechanics of this simple Penrose drain or collapsible tube, we stumbled on the fact that you can't ever suck the airway closed. You can breathe in as hard as you want, but the increased effort swings that you see on your sleep studies are a consequence of the obstruction, not the prime cause or movers. And the situation really bore an analogy to what might be considered a waterfall, and I think you probably recognize this one. Pardon me?
Know this one very well.
Not this one?
No,
You know this one very well. Yeah. This is Iguazu Falls at the border of, this is the Brazilian side.
The British side.
Yeah, okay. So we won't speak about the other country on the other side. But really the concept was that if you model the flow across this waterfall, you can breathe in and lower the pressure in your trachea or make the waterfall higher and higher and higher by lowering the base of the waterfall. And you don't get any more flow across the waterfall. The flow is fixed. It is what it is. It's at a maximal level. It doesn't increase as you lower the downstream pressure to that waterfall. And in fact, the only thing that will, and we saw this, and we saw this very clearly within a single breath. It really only took one breath during sleep to realize as you look at the flow going into, maybe? I don't know. Oh yeah. As you look at inspiratory flow, the start of inspiration is here. More flow going into the airway is shown by a downward deflection. And you see that as the effort increases and the pressure goes down considerably, the flow here reaches an early plateau and no longer responds to increasing effort. Again, our waterfall condition is seen here during each and every snore that your patient makes. And so sure, he can breathe in as hard as he wants, but it's not going to help his ventilation. And so we had to look elsewhere in explaining, hey, what determines how much the airway obstructs? If it's not how hard you breathe in, then the only other option is really what's going on upstream. And upstream is actually in the CPAP mask. And so those three characters who were on CPAP, not only was that therapeutic, but we slowly began to realize as we looked at the flow profiles of patients breathing on CPAP, we slowly began to realize that, hey, there's more information diagnostically in the patient's breathing patterns that we were able to induce simply by changing up the level of CPAP. And in fact, the analogy here is to really is, here's the downstream side, and you've got a series of weirs where the downstream pressure falls considerably from one step to the other. But the flow across the first upstream waterfall stays the same. Doesn't matter how many weirs there are downstream, how low the pressure gets. Once again, downstream pressure doesn't impact the flow. On the upstream side, this is the gristmill in New England. Yeah, if you've had a huge rainstorm, the height of the pond goes up. And it's that upstream pressure, which is the equivalent of our CPAP, that drives more flow over the first of those waterfalls. And really, it's that upstream pressure that governs the flow in every respect, because as you, I want to just advance slides if you want to just have a seat. Yeah. Thanks so much. As you look at it and you do a normal CPAP titration study, you can see that as you raise the nasal pressure here on the x-axis somewhere, as you raise nasal pressure, you get increasing levels of inspiratory airflow. That plateau flow goes up, up, and up. But not only do you get more flow through the airway on a breath-to-breath basis, But you see that the disease process changes from complete obstructive apneas to hypopneas to a term that was coined here called upper airway resistance syndrome, or later dubbed RERAs, respiratory effort-related arousals. Finally, primary snoring without the oscillations in flow and the desaturations and arousals, and then finally normal breathing. And for years we thought that all we had to do was really summarize the collapsibility of the airway just by looking at the level of nasal pressure at which the airway just starts to crack open. And we'll call that pressure the critical pressure, literally the pressure surrounding the Penrose drain, as simply a quantitative metric or measure of the collapsibility of the pharynx. Again, no connection to anatomy whatsoever. We're just thinking concepts here. But you all are much more familiar with a different pressure. And this one is really one that we're just recently working on. It's one that's been around for years. This is the therapeutic CPAP pressure. This is the pressure that APAP machines automatically hunt and find. And yet we're doing preciously little with that measurement of the collapsibility of the airway. But I would submit to you that as you think about planning your surgeries and your orthodontic work and what have you, that quantitative measures of the collapsibility of the airway, just as you're highly precise in dialing in certain levels of readjustment of teeth and skeletal structures and soft tissues, that quantitative measures of collapsibility can help you figure out which patient to select for which procedure. And that's really the holy grail of personalized medicine, is in addition to all the creativity and the modeling that we've heard spoken about this afternoon, really important to know who the best patient is. Now, I heard about 3 Bs. One of those is breathing. And we've got to sort of figure out in whom we can apply enough of a breathing manipulation, whether it be surgical or not, to lower the therapeutic CPAP pressure, the green dot here. And we'll call that dot the pharyngeal opening pressure and distinguish it from the critical pressure, which is the bottom of this curve. The pharyngeal opening pressure, I'm going to call it the FOP for short. The goal of every one of your procedures is to drop the FOP. Because if you don't drop the FOP, this is going to be our mantra together for the next few minutes. If you don't drop the FOP toward atmospheric pressure, you haven't effectively treated your patient. And I'd submit to you for any kind of procedure, whether it be expansion palate or MMA, if we had some a priori notion how much we can drop the FOP, we might have a better idea whether we can actually effectively treat our patients and get them off CPAP. And so we're going to talk about acute manipulations really designed to drop the FOP and get patients off CPAP. Next slide. Yeah, that's fine. Keep going. Well, in the past couple of years or so, I've had really the fortunate experience of interacting with a couple really bright young ENT surgeons. One is David Kent at Vanderbilt. You'll hear about his work in a little while. And the other is Raj Dedhia at University of Pennsylvania. And because of the advent of the Inspire systems, DICE procedures are really being done, left, right, and center in evaluating patients for a variety of PAP alternatives, including a hypoglossal nerve stimulating device. Well, you all know that. But what we did is we took the usual visual exam that really reveals the anatomy, and we developed just a simple protocol to run a straightforward, telescoped down, short-lived CPAP titration study. And lo and behold, what we see is that we've recapitulated every step of a CPAP titration response in the sleep laboratory, but we've done it under propofol anesthesia. Literally put a CPAP mask on them, an endoscope that is poked in through a hole in the mask. So we're looking at the airway. We also happen to have a couple catheters in the airway, so we're able to measure pressure. And we're measuring flow, airflow, just as we've seen, as we step up, in this case, step up the level of CPAP, or nasal pressure, in very, very brief increments. And you can see that at the low level at atmospheric pressure, we've got a complete obstructive apneas with zero flow here, and pressure swings, huge pressure swings, in both the upstream and the downstream catheter. And these are recurrent events with desaturations, despite the fact that the patient's on propofol. You can see the entire picture of obstructive apneas are recapitulated during the DICE procedure. But as we step up the pressure, in this case to about 4 or 5 centimeters of water, the apneas give way to hypopneas. They are obstructive. We see the same plateauing of inspiratory flow. And then at a certain point, we see flow limitation. The airway is partially obstructed, but no longer oscillating. The desaturations tend to go away, and the breathing pattern stabilizes. And in fact, you can measure really 2 easy points, metrics of airway collapsibility, namely the critical pressure, which is exactly at this point where flow just begins. The airway is just cracked open by the CPAP pressure at some low level of about 4 or 5 centimeters of water. And at this point here, the flow limitation actually goes away. And as it goes away, as we said a moment ago, the pressures in the airway melt away at the same time. Airflow obstruction remits. This is the equivalent of the effective, minimally effective CPAP pressure. The pressure that the APAP machines are hunting for all night and revising as they alter the pressure a wee bit here and there. And so on your APAP reports, you get a measurement from the compliance reports, and it tells you, hey, how much time did at what level of pressure did the patient spend 90 or 95% of the night on? That pressure is roughly equivalent to what we're measuring here. That is namely the FOP, the pharyngeal opening pressure, when all evidence of airflow obstruction goes away. Now we're correlating a lot of this, and a lot of this stuff is work in progress as we correlate a lot of the physiology with the anatomy that you all are comfortable in assessing. But we can go ahead and make measurements of the physiology as we've enhanced the normal DICE procedure and begin to correlate. Now I heard some talk this afternoon about really squishing the tongue in the transverse dimension. Well, it turns out in a cross-sectional study that we're now in the midst of preparing, the more the tongue is squished in the transverse dimension, the higher the pharyngeal opening pressure. As a simple example of how we can begin the process of linking your observations with those of a respiratory-oriented physiology crowd. And the same thing happens here. As we plot out the flows as a function of nasal pressure, in the next slide you'll see that we can really generate the same idealized, stylized curve that we showed earlier, where the critical pressure here is literally the level of CPAP at which the airway just begins to crack open, and the FOP, the pharyngeal opening pressure, when all airflow obstruction goes away. And so let's carry that concept forward as we go into the next portion. And that is, and we can skip through this in the interest of time, we're going to go ahead and see what it takes as we sort of model the process of airway obstruction. And I would submit to you the following, is that while we can measure a collapsibility parameter like a P-crit or a FOP, that as the collapsibility improves, in this case the P-crit goes more and more negative, the disease process, and there's abundant papers from lots and lots of people showing that these measures of collapsibility are absolutely linked to the severity of the clinical disease process and the manifestations of either complete apneas, hypopneas, snoring, or completely unobstructed normal breathing. But as the collapsibility of the pharynx improves with your surgical interventions, we'll also see as you go in stepwise fashion through these disease categories, you will see an increase in inspiratory flow by roughly 150 mLs per second. And so as quantitative as you are, as you plan your skeletal surgeries and really map the anatomic structures, what we're adding to the conversation here really is that you've got easily accessible metrics that can be embedded on your routine exams to really literally quantify the effects of an experimental manipulation on a breath-to-breath basis. Next slide. So let's illustrate the point, and what we're trying to do is identify therapeutic mechanisms using electrical stimulation as a tool. We'll look at some of the older work where the hypoglossal nerve was stimulated simply because everyone thought in the 80s and 90s that the genioglossus muscle had to be important. It's a big muscle, controls the position of the tongue, and if you can only sweep the tongue out of the way by activating the genioglossus muscle, you should be able to restore airway patency. If we look at the airway as a collapsible tube, literally in cross-section, pulling the tongue out of the way is the equivalent of lowering the tissue pressure surrounding the airway. And in fact, that's been demonstrated really in physiologic studies quite well. That the effects of genioglossus stimulation are that it provides a tethering or a radial force pulling the walls of the airway, whatever it might be, outward. To gain a little bit more anatomic specificity, if the tongue is lying on the back of the soft palate, if we pull it away from the soft palate, perhaps either through direct contact, a zone of apposition, or attachments, coupling of the tongue to palatal and lateral wall structures, we can actually affect quantitatively an improvement in the collapsibility, a reduction in the collapsibility of the airway. And so that was the notion behind hypoglossal nerve stimulation originally. Next slide. We knew that the airway had a lot of different sort of states of activation. And as I mentioned, the tongue was a big muscle, and if only we could recruit the genioglossus muscle and pull the tongue out of the way, we'd be okay. Now we found early on, as you hit one more time, in response to airway obstruction, the patient will obstruct, but over time during sleep, these muscles of the upper airway, including the genioglossus, start getting recruited. And with recruitment of these muscles, the airway tends to open up. The collapsibility of the airway goes down, and the instantaneous level of airflow on any particular breath increases. And so that's the process that we went through in the next slide, just stimulating the tongue muscles. We did it initially really crudely with fine wires and a transcutaneous TENS stimulator, one of those pain relief devices. Next slide here. We went through a process. We had an animal model of an isolated upper airway. We grabbed onto the hypoglossal nerve. We found that we could decrease the P crit. We could relieve the airflow obstruction. We did it during sleep with fine wires. We did it during anesthesia. We nailed down some of the mechanisms. And then finally, as we sort of spin out into the late 1990s, early 2000s, Medtronic, a pacemaker company, decided to pull a couple of off-the-shelf components, package it up, and we did our first fully implantable studies on patients, both in Europe and the United States. And we found that, lo and behold, we could get some improvements in the AHI. The AHI improved, but as we understood with some of the pilot work that followed in the years, the naught years of the 2000s, that we really scored a safe ground rule double, but we were not necessarily fully effective or effective in treating each and every one of the patients. Well, let's see what the response is in the next slide. We also, by the way, identified different sites of stimulating the hypoglossal nerve. You saw that on the last slide where we initially started actually stimulating way back through the oral cavity roughly placing wires in the vicinity of the proximal hypoglossal nerve. First patient that we stimulated with these fine wires in that location, stimulation completely slammed the airway shut. We had 17 centimeters of water CPAP and a completely occluded airway when we stimulated. Well, needless to say, that was good news and bad news. The good news is the patient actually slept through the study. The bad news is we achieved the opposite of a therapeutic effect. And so we hunted around, and really out of naivete, I was not aware of distal branches, something that's routine for you guys at this point. But we slowly sort of worked our way forward and said, hey, there's got to be something more to this. We went back to some old animal work in the 1930s that had been published that said there is a lateral and a medial branch in dogs and cats, and essentially reinvented some of the old anatomy. But again, reflecting the naivete of a dumb respiratory doc who's trying to apply some of this stuff to the upper airway. In one of the implanted patients from Medtronic, what happened was we turned the stimulator on once the patient got off to sleep. And so at the vertical dashed line, you see that we turn the stimulator on and we convert a patient who had complete obstructive hypopneas with recurrent desaturations and arousals. We turned them into a relatively normal and stable breathing pattern. And so that was the therapeutic effect that was highlighted by the improvement in airflow. And then as a result of the improvement in ventilation, what we see here is that the oxygenation improves and sleep continuity improves. But there was a glitch here on this recording, and you can just hit the slide one more time, because this stimulator, like the current Inspire device, is actually synced up with the respiratory cycle, but the syncing was not so good. I'm not sure how good it is now, but it wasn't so good. And it missed a breath or two, and surely enough, when at the red asterisk, as the stimulator lost its way and failed to track the inspiratory phase of the cycle, what we saw was really clear. The airway shut down and went right back to its previously obstructed state, shown here in the obstructive hypopneas on the left-hand side. But what we saw here, a mistake of nature, was that we can actually measure breath-to-breath, on-off responses, and model not just the improvements in the respiratory patterns that we're all looking for ultimately, but we can model quantitatively with one breath on, one breath off. You can see immediately what the effects of a particular intervention are, like electrical stimulation. Well, if we fast forward in the next slide and we look at the STAR trial, which is Inspire's pivotal trial for FDA approval of our first hypoglossal nerve stimulating device, we see that 2/3 of their patients showed really substantial and remarkable reductions in AHI on the left-hand side. But the other 1/3, namely on the right-hand side, each individual patient, really fluctuated a bit, but there was really no consistent improvement. And so we began to scratch our head with data like these and others to say, hey, what distinguishes a responder from a non-responder? Well, the first thought that occurred to us is really how much were we able to really improve the airflow? Not just are we able to get a qualitative response, but by how much can we do it? And so we saw a tracing like shown on the next slide, where we had another device, it happens not to have been the original device, another device that stimulated sort of willy-nilly, kind of in synchrony, sometimes with respiration, sometimes out of synchrony. And the stimulus artifact is shown here in the EMG trace, the large ink splatter of black, that overlies one inspiration in the middle of this chart. And you can see inspiratory flow once again in the downward direction during the stimulation is roughly double the obstructed or partially obstructed flow that you see in the non-stimulated breaths. And so this was a pretty good result. But we did not, in this recording, take the patient from complete apnea to completely open. But rather, we took the patient from a degree of partial obstruction to less obstruction, but still a hell of a lot of snoring artifact that you can see in the airflow trace, the high-frequency chatter. It means he's still snoring and at least partially obstructed. And if you look again a little bit more, we can continue on, I don't know. Yeah, you can continue. Yeah. If we go back to our sort of rubric, our pressure flow plot, CPAP on the x-axis, airflow on the y, this patient at that moment in time had an obstructive hypopnea, and we took the flow almost right back up to the flow that you would see at the pharyngeal opening pressure, the FOP. But that's not always the case. Now, if we're able to achieve that level of airflow, the apnea will melt away, and that's the end of the story. The patient is fully treated. But you'll see in the next slide that this same patient had a complete apnea at another point in the sleep study, where the stimulation again hits a few inspirations right smack in the middle of a complete obstructive apnea. And lo and behold, what you see there is no response whatsoever in airflow. So once again, quantitatively, on a breath-to-breath basis, we can easily discern the magnitude of the response. And we might sort of conclude in this patient that, yeah, someone who's got obstructive hypopnea, it's not quite so heavy a lift. We are able to restore ventilation, airway opening and ventilation. But in the next slide, we'll contrast those two modes depending on the severity of airflow obstruction. A partially obstructed airway, we really improve. The one that's in complete apnea, and I think that's the next slide perhaps, most of this upward arrow is actually below the axis. In other words, we get nothing out of it, no increase in inspiratory flow. The increases in flow are really small potatoes, small stuff. And so the concept that emerges here really is that depending on the state of airflow obstruction or the collapsibility of the airway, you might actually have a better or a worse chance of effectively treating your patient. And now if you fast forward, Raj Deddy and Everett C. found that when they took a handful of their Inspire responders and non-responders, in the left-hand side you can see, this is the pharyngeal opening pressure that's represented for the responders compared to the non-responders. And the responders had a lower pharyngeal opening pressure than the non-responders. So as a potential predictor of response to hypoglossal nerve stimulation, just needing less CPAP to fully open your airway may be a promising candidate and might end up enriching your patient population for responders. Just by knowing, once again, that APAP pressure, the 90 or 95% number, CPAP level at which the patient spends most of the night asleep. And they've done receiver operating curve. They've done a little bit of corrections and adjustments for age, sex, and weight. But the orange curve basically shows you that they get somewhat enhanced responses once they've accounted for the pharyngeal opening pressure. Namely, it's easier to drop the FOP in someone who starts out here with a FOP of 5 or 6, to drop the FOP to atmospheric pressure, relative to a non-responder who starts with a median level of about 10. Well, if we take that and carry that forward, the kind of experimental and study flexibility came to fruition with another hypoglossal nerve stimulating device. The next slide. And this is actually a device that grabs onto the proximal hypoglossal nerve. That's a no-no for Inspire. You spend a lot of time in the OR trying to dissect out distal branches, exclusion branches, etc. But this is a device that, for whatever reason, was designed to sort of grab onto the proximal nerve. But rather than stimulate the whole nerve at the same time, it stimulated different sectors of that nerve. It too has a pacemaker can, it has a lead body, and a circumferentially arranged electrode over one of the hypoglossal nerves. But as shown here on the left-hand side, there are 6 contacts, each of which can be stimulated at different levels of juice, of stimulation energy, however you want to define that, in order to activate a specific portion of the nerve. And so that creates a sort of therapeutic titration nightmare. The degree of flexibility or permutations that you have between titrating 6 contacts at different levels of stimulation becomes insurmountable inside of a single night of study. And so we had to develop a way, an approach to quickly sort of zeroing in on the 2 or 3 contacts that might be effective in opening the airway. Went back and once again dialed the clock back, as you see here in the next slide, and looked at the single breath responses, contact by contact by contact. But because the unit of measure is the breath, not the apnea, we can get at the answer much quicker. Because you can see, and we can score them, but you can see that for any particular contact, again looking at your airflow trace, perhaps in the middle panel here you get more flow when you're stimulating than the adjacent breaths on either side. That was an indication of the fact that that was a particular portion of the proximal hypoglossal nerve that might yield a therapeutic response down the line. And so we began to systematize our therapy customization titration techniques using the single breath as our unit of measure. And that yielded ultimately the following results, because if you want to go to the next, you know this guy, Tomas. We took a look at a handful of these patients and said, hey, what's the difference between a good contact and a bad contact? And the difference turns out when we looked with ultrasound at the shape and the position of the tongue, the difference turned out to be the shape of the tongue was very different in those who responded and didn't. Hit one more button. Here's a contact that actually slams the airway shut, just as I described a moment ago. When we stimulate, we get zero airflow. This is an obstructive apnea. And lo and behold, yes, we're getting tongue protrusion, but we're not getting a balanced recruitment of the tongue musculature. Because if you put the tongue in a vise and squish it against the back of the mandible, you guys have more precise terms. It'll bulge out here or there, maybe on the top and the bottom, and may actually, the bulging, the jello, if you will, may push back on the pharynx. Whereas on the other side here, where we get a positive response, an increase in airflow, shown here in the stimulated breaths at the bottom, we see the increase in airflow is associated, yes, with a similar degree of forward movement of the hyoid bone, but the tongue shape is relatively preserved. Meaning we're getting probably, and this is the inference that we're making, we're probably getting a balanced recruitment. So now we've got sort of 2 indicators of potential responses to hypoglossal nerve stimulation. One is how heavy a lift is it in terms of airway collapsibility, namely the FOP. Can we drop the FOP enough? And the second is what are we doing actually to the tongue itself? Are we preserving its shape in addition to pushing it forward or not? And ultimately, the results are shown here for an extended trial, similar selection criteria, although somewhat enlarged selection criteria relative to the Inspire STAR trial. 138 patients were implanted, moderate to severe sleep apnea with an AHI going up to 65. They're obstructive, they're PAP intolerant. The BMI was allowed to ride up to 35 rather than a cap at 32, as was the case with the STAR trial. They were implanted and randomized, and this was a randomized controlled design here. So in the treatment group, they were turned on after 1 month of healing, and in the control group, treatment was deferred until month 4 plus 1 day. And we see that lo and behold, in the active treatment group at month 4, the AHI goes down, quantitatively by about the same number of events per hour that the AHI went down in the Inspire STAR trial. It's just that these patients who are a little bit more chunky started at a somewhat higher level of AHI in the first place. But quantitatively, the metric is really, the response is about the same. And then when we cross them over at after almost a year of therapy, we crossed the controls over and started stimulating them. They too responded in a similar fashion. Another interesting item is there's been a lot of talk and bandied about concentric collapse, complete concentric collapse. But CCC was not evaluated in this study. There was no DICE procedure whatsoever. And so the responses that we see presumably are occurring across the board in some patients with and without CCC. And in a somewhat enlarged group, expanded group based on the BMI. Yeah. They're in the mid-50s to about 60.
I got you.
Yeah.
And positional were the excluded?
Positional was excluded. A definition is you couldn't go below 10 when you were on your side, an AHI below 10.
Excellent. So it's shown
Yeah.
then the
Yeah. And similarly with REM-related, isolated REM apnea.
Okay.
Yeah.
Thank you.
So again, very basic concepts. My guy Mike from the ICU, who came back as a pulmonary fellow, would have been bored to tears by this. And I always say at about this point that if I've put you to sleep, I've accomplished something. I know I have. But let's look at some new work, and this is primarily the genius and the creativity of Dave Kent at Vanderbilt. He's looked at stimulating in a different direction. We've spoken about hypoglossal nerve stimulation, sort of unloading the airway, but really more from the point of view of the surrounding pressure and tethering forces. Ansa cervicalis is really involved with innervating strap muscles that pull down on the airway. And the idea, really, the genesis of the idea came in the next slide, where we know that sleep apnea is highly linked to obesity. Well, what is it about obesity that connects obesity to the upper airway? We know that obesity and central adiposity deposits fat tissue in the tongue, and we saw some ultrasound pictures this afternoon. But the other main effect of obesity, and central adiposity in addition, is really the fact that it squishes the lungs. The diaphragm rides up high. The lung volumes are dropped. And the lung volume goes down. This ERV is a measure of the resting lung volume and how much room or reserve we've got between sort of the resting lung volume and the bottom of the lung, so-called residual volume. And when that little quantity goes down, and it really does go down as a function of BMI, you know that your diaphragm is riding high. But not only that, in the next slide, you know that there's less traction, caudal traction on the airway. And so this, again, the simplistic, non-anatomic respiratory view of the airway was one of a finger trap. And the finger trap, as you increase the lung volume in the lower left-hand corner here, the finger trap became stiffer. Yes, it might be a narrower finger trap. The caliber might not improve, but the stiffness, the collapsibility can. And stiffness or collapsibility is a question of airway function, not airway structure. And so what you see on DICE can be accurate in some respects, but in another respect, it may not directly relate to function or collapsibility of the airway until we get a little bit more sophisticated. And so the notion that we went through, and we really teed off in the next slide, a bunch of lines of evidence really served to convince us that perhaps in animals and also in humans, you could actually apply caudal downward traction on upper airway structures and decrease the collapsibility in a bunch of animals and also human studies, relieve airflow obstruction, improve the ventilation, and even some studies out of Boston show an improvement in AHI. But the missing link was really provided by you all, and specifically David Kent, who really just tooled away in cadavers and DICE patients trying to figure out what part of the ansa cervicalis might be active in causing this kind of downward pull on the airway. And in the end of the day, he really, and this is really genius on his part, I take no credit for this whatsoever, he identified a little twig of the ansa cervicalis, which in the next slide can be seen, down here at the base of the neck. And I'll rely on you all to sort of generate the anatomic specificity. Figured out how to image it acutely under ultrasound in his patients coming for DICE, and place fine wire needle electrodes in that vicinity, recruiting specifically the sternothyroid muscle. And when he recruited it, what you saw is that there's downward traction on the laryngeal complex. So no question about it. You're getting the traction. The question is, what does that translate to in terms of airway collapsibility? And so I'd like to just show a quick clip from Dave's files showing the anatomic view of the airway in the left-hand side and the physiology here on the right-hand side. If you want to just stop it for a sec and maybe scroll it back, all the way back. There's a stop button there. Yeah. So just to get you oriented, I think you probably understand the endoscopic image. The stimulation patches are being applied once again on a breath-to-breath basis. A couple breaths on, a couple breaths off, at a fixed level of CPAP. And you can see in the green channel here the airflow trace. Now, inspiratory flow happens to be in the upward direction. This is a flow-limited breath that I'm pointing to in the middle of this. And then when the stimulation turns on, the flow doubles. We're stimulating for 2 breaths. We're bracketing that stimulation with off breaths on either side. And again, the comparison is breath to breath. How much of an improvement in airflow do we see? And what is the correlate visually on the endoscopy? And so I'll call it out when you start to play the... That's an off breath, but you can see an on breath here, and maybe stop it in the middle of the stimulation. Yeah, perfect. Can you stop it? Yeah, okay. All right, so you try it again, and I'll try and just call it out based on the video endoscopic images, which are really quite clear. You can see that this is a patient whose lateral walls collapse. In fact, everything is collapsing. Palate and lateral walls are collapsing. And now stimulation goes on, and the lateral walls are stabilized. Stimulation goes off, and once again, the picture shows collapse. On, stabilization, off, the lateral walls collapse. And those images correspond to the improvement in airflow and ventilation in the physiology during DICE. So Dave went on, and we yapped a lot, and we had a lot of time during the pandemic to sort of yap what's the best experimental paradigm, and you can continue to the next slide if you'd like. And we said, well, can we measure the amount of airflow that you get? And here we see in the middle of this panel a complete obstruction, off stimulation, but on stimulation we see huge improvements in airflow. And we can quantify the airflow. And we said, hey, 150 mLs per second increase in airflow will take you from an obstructive apnea to a hypopnea, or from a hypopnea to a primary snoring picture, or snoring to. And so when you're dialing in, and now DICE is just a model for what might be happening during natural sleep, you're seeing the airflow goes up from a little over 200 mLs per second to something up in the stratosphere, but even nominally speaking, about 500 or 600 mLs per second. So maybe 2 disease categories here. These are pilot data. We sort of nutted the protocol out a little bit more, began to generate different responses at different levels of CPAP in the next slide. And we see that here, where in the left-hand panel, this is Yi-K Lee, who has been involved with these studies in the OR. We see the CPAP pressure reflected in the bottom panel here, where the CPAP goes from about 6 or 7 centimeters of water down to about 4 centimeters of water. Again, the stimulation periods are shown in the yellow compared to the adjacent breaths in the blue. And you can see that every yellow period shows an improvement in airflow relative to the blue. And when you plot those out on a flow versus pressure plot, you can see that there's a parallel shift, roughly speaking, and a drop in the FOP by about 2 centimeters of water, and summarized here. Drop in the P crit and a drop in the FOP by about 2 or 3 centimeters of water. Well, what does hypoglossal stimulation produce? Well, the existing measurements, which are not all that many, show about a 3.5 centimeter of water response to hypoglossal stimulation. Add to that perhaps another 2 or 2.5 centimeters of water, trying to figure out who the responders and the non-responders are with some of these acute breathwise studies. And maybe we've actually got a treatment for those who are not responding to hypoglossal nerve stimulation alone. Again, it's not just about treating, it's about modeling quantitatively the magnitude of the effect to the acute manipulation. And then the last step here is really to combine the, you can continue to click through 1 or 2 clicks here, combining the two, and we've thought for a number of years that if you click once again, if you combine the hypoglossal with the ansa cervicalis stimulation, will you achieve, in fact, a better effect overall? Primarily because the vectors can sum to really pull structures in positive, in beneficial directions, both by diminishing the surrounding tissue pressures as well as by tautening or stiffening the airway along its entire length. And the pilot data are shown here, again from Dave Kent, in the next slide, showing that cross-sectional area is represented on the right-hand panel here. Ansa cervicalis stimulation alone, that's the cross-sectional area, about 200. Hypoglossal alone, maybe a little less than 200. But combining the two, generally speaking, leads to an improvement in the overall patency of the airway. And that improvement can also be reflected by the bump up with combined stimulation and airflow compared to just hypoglossal stimulation alone. That's the left-hand panel. So I'd like to summarize to say, hey, where have we gone? Well, you know, this is a process here. But the functional implications of what you are doing on a day-to-day basis and using stimulation, electrical stimulation as a model for the kinds of effects, we really come away with the notion that the airway function in the next slide really is determined, its collapsibility is determined by 2 broad physiologic constructs. One is the surrounding pressures, the external pressure. We've called that P crit in the past, but we're breaking up P crit into at least 2 components: the surrounding tissue pressures and the stiffness induced by longitudinal or caudal traction on the airway. So I'd like to summarize here just with a couple take-home points. Quantitative metrics of airway collapsibility can be derived from routine CPAP titration studies during DICE and natural sleep from your APAP downloads or your CPAP titrations. That's useful data that we have generally tended to ignore, but may well help to guide some of your surgical selection issues. If effective, the PAP alternatives will drop the FOP to atmospheric pressure. And we can do that in one of 2 ways. We've got to select patients based on low levels of FOP, perhaps initially, and we've got to quantify the effect of your procedures, whether they be orthodontic, dental, or surgical. We've got to quantify the effects, the magnitude of the effect, the overall effect size. By how much do we drop the FOP? We've seen that the acute breathwise responses can simulate therapeutic effects. They can help us not only with the therapeutic effect and nutting out a new form of therapy, like hypoglossal or perhaps in the future ansa cervicalis stimulation, but we've also seen that we can simulate these effects in different patients and really understand the human range of variability that is going to keep you all busy for the rest of your natural professional lives. And we've also seen early evidence that pharyngeal patency can be best restored with strategies that both dilate and stiffen the airway. There's a lot yet to be learned, but a lot of crosstalk. And I think that this symposium and all of the colloquia that have gone on this afternoon really emphasize the point that not only is it fun to talk with your colleagues again, finally, but it can actually be useful and extraordinarily productive for your patients. I'd like to conclude with the last slide.
I don't know if it's gonna make sense.
All right. Well, thanks. Thanks so much. I know I've gone over.